Medurstand. Understanding medicine. Medurstand. Understanding medicine.
This is Professor Azizur Rahman, and we have covered the entire spectrum of valvular heart diseases: mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, mitral valve prolapse, HOCM, tricuspid regurgitation. I think now is the time to have a quiz. Let's have it. Now, the format is that it is actually not the testing your knowledge. You will test your own knowledge, but this will provide you an opportunity to do that. And also, if there are points which needs some further discussion, I think we will do that also. So this is a kind of a revision of valvular heart disease. Now let's have the first quiz. Which one of the following is the characteristic murmur of mitral stenosis? You have the choices of pan-systolic murmur, early diastolic murmur, systolic ejection murmur, mid-diastolic murmur, and continuous murmur. Which one is the most characteristic murmur of mitral stenosis? It is listed here. You just have to pick one, which is the right one. I guess you have done it correctly. It is mid-diastolic murmur. Mid-diastolic murmur, which is best heard on the mitral area, which is apex beat, and it is rough and rumbling in character, and it does not radiate anywhere. And it is best heard with the bell of the stethoscope. Right. Let's see the next one. Which statement is true regarding atrial fibrillation complicating mitral stenosis? This point was emphasized that people with mitral stenosis are more prone to develop atrial fibrillation, and that can certainly change the disease scenario, and patient becomes more symptomatic, and you just have to pick up the true statement of all the listed here. Patient may develop pulmonary edema. Patient could develop pulmonary edema otherwise also, patient with mitral stenosis. But once atrial fibrillation occurs, it increases the chances of him going to pulmonary edema. And second is pre-systolic ejection murmur may disappear. Risk of thromboembolism is increased. Pulse becomes irregularly irregular. And all are true. Which single statement you consider to be true? Yes, all are true. Because patient may develop pulmonary edema because with atrial fibrillation diastole becomes shorter, and it is diastole during which left atrium empties into the left ventricle, and in cases with mitral stenosis till the end of diastole left atrium still is not empty, and if diastole is further shortened, that of course makes the situation worse. Pre-systolic ejection murmur may disappear. Yes, pre-systolic accentuation in mid-diastolic murmur is caused by atrial contraction, and in atrial fibrillation there is no active atrial contraction. Role of thromboembolism is increased. Yes, the rhythm is irregularly irregular. Any irregularly irregular rhythm predisposed to thrombus formation and its embolization. Pulse becomes irregularly irregular. That is the inherent feature of atrial fibrillation. So all are true. Okay. Next, take the next question now. The medical treatment of mitral stenosis may include beta blockers, digoxin, diuretics, warfarin, or all are true? All are true. Beta blockers help by reducing heart rate if the rhythm is sinus. Digoxin does the same if the rhythm is atrial fibrillation. Diuretics, they remove some fluid and pull the patient out of pulmonary edema. Warfarin is anticoagulant and reduces the chances of thromboembolism. So all these medicines are useful in patient with mitral stenosis. Next question. Which one of the following does not reflect the severity of mitral stenosis? You know, the actual way of measuring the severity of stenosis is by actually measuring the orifice size on echo, and also by seeing the chamber size of left atrium, left ventricle. You can actually measure the pressure. So that is the actual way. But on the bedside, in the traditional medicine, in the bedside, you can actually have some idea about the severity. Now, I'm going to list some feature and you tell me which one does not reflect the severity of mitral stenosis. Severity of dyspnea, extent of crepitation. That means the crepitation are heard just on the bases, or they are heard on the up to the middle zone, or the up to the apices. Intensity of the murmur, how loud the murmur is, duration of the murmur, and proximity of opening snap to P2. Which of these does not reflect the severity of mitral stenosis? That implies all others do. So which one actually does not reflect the intensity of the mitral stenosis? It is the intensity of murmur. Many students would think the louder the murmur, the more severe the stenosis. That is not actually true. Sometimes the stenosis may be real bad, very advanced, and the valve is so badly damaged that it doesn't vibrate. And you wouldn't have murmur unless the valves they actually vibrate. So intensity may be very faint, whereas the stenosis may be very severe. So there is no correlation between the intensity of the murmur and the degree of stenosis, whereas all others they have some kind of correlation with the severity of mitral stenosis. This one is murmur of mitral stenosis is characterized by all of the following except. So these are the features of mitral stenosis. There's one which is not. It is best heard on mitral area. It radiates to the axilla. It is rough and rumbling in character. It increases during tachycardia, and it is better appreciated with the bell. Which one is not true? Because it says the mitral stenosis is characterized by all of the following except this one statement which is not true. The murmur of mitral stenosis does not radiate anywhere. It is the murmur of mitral regurgitation which radiates to the axilla. So all are true except that the murmur of mitral stenosis does not radiate to the axilla. It is actually heard on a very small area, and if you do not examine the precordium thoroughly, then you could actually miss this murmur. So be sure that you examine every bit of this precordium not to miss this murmur. Let's take the next question now. Percutaneous transseptal mitral commissurotomy is in mitral stenosis is contraindicated in except when there is is contraindicated except when there is a clot in the left atrium. That means in all conditions it is contraindicated. In one condition it is not. A clot in the left atrium. Patient of course has mitral stenosis. Patient has mitral stenosis, and if there is a clot in the left atrium, there is associated significant mitral regurgitation. There is associated aortic regurgitation. The mitral valve is tight, or there is calcific mitral valve disease. So, in which you think PTMC is not contraindicated? In all others, PTMC may not be a great choice, but in one it is perfect choice, is not contraindicated. Tight mitral valve orifice. In fact, that is the reason we do PTMC. But no matter how tight, if it does not have calcification, if there is no associated regurgitation, no aortic valve disease, and no clot in the left atrium, no matter how tight, as long as you can pass your catheter, I think you can do a good job. So tight mitral valve orifice is not a contraindication. Others are contraindication for PTMC. What is the commonest heart disease in college-going students? This is a little funny. Of course, you will be able to figure out. Commonest heart disease in college-going students. Congenital heart disease, of course, likely, because sometimes congenital heart disease persists till adulthood. Rheumatic heart disease, again, young people have. Ischemic heart disease is unlikely because the medical students are young students. And then ischemic heart disease. It's from the word ishq. So that I guess is most likely. But this was, I think, only make a little light joke. So this was all about the first part of the quiz, uh, predominantly on mitral valve. But we are going to have another quiz. Please join me in my next quiz, which is again on valvular heart disease. This is Professor Azizur Rahman from Medurstand, Understanding Medicine. Thank you.